Usually when we think about body fat, we picture it as this inert biological storage unit.
Right, just sitting there.
Exactly. Just a passive depot for excess calories. Kind of like a biological savings account that we simply haven't tapped into yet.
Yeah, and I mean, that is the widespread underlying assumption in so much of our cultural conversation about weight, that it just sits there until you need it.
But then you look at the actual metabolic science, and suddenly that assumption just shatters completely. We are looking at a physiological landscape that is far more aggressive.
Oh, absolutely. It's a profoundly different picture.
So for the medical students, young professionals, and rigorously curious learners joining us today, welcome to our deep dive. Today we are exploring a really comprehensive overview of gynecological health, specifically through the lens of metabolic science.
And we're basing this off some incredibly detailed source material, specifically the textbook Obesity and Gynecology, 2nd edition.
Right, and our mission today is to map out how adipose tissue fat tissue is not passive at all. It is, in fact, a highly active rogue endocrine organ.
It really is a profound misunderstanding of human anatomy to treat fat as just storage. I mean, this tissue actively pumps out hormones and inflammatory markers.
It's essentially hijacking the body's normal physiological signaling.
Exactly. And if you want a rigorous understanding of metabolic science, you have to understand how this unauthorized gland alters the baseline of everything, from the onset of puberty all the way to the complexities of menopause.
So let's trace that timeline, starting right at the beginning with early onset, how childhood obesity fundamentally alters adolescence. Because we're seeing an acceleration in the onset of puberty across the population.
We are, yeah. And it comes right back to that rogue endocrine organ concept. Adipose tissue is actively producing excess estrogen.
But wait, I have to stop you there. How is fat producing a reproductive hormone?
It comes down to an enzyme called aromatase. Adipocytes, fat cells, contain a really high concentration of this enzyme.
Okay.
And aromatase's primary job in this context is to take circulating precursor hormones, specifically androgens like androsten and eoni.
Which are typically thought of as male hormones, right?
Right. And it takes those androgens and converts them into estrone, which is a form of estrogen. So the more adipose tissue a patient has, the more of this peripheral aromatase activity occurs.
Wow. So it's creating a massive secondary source of estrogen entirely outside of the ovaries.
Completely outside the ovaries.
Okay.
And that completely scrambles the hypothalamic pituitary ovarian axis, the HPO axis.
Because usually that's a delicate, tightly regulated feedback loop between the brain and the ovaries, right? The one that dictates reproductive maturity.
Exactly. But now the brain receives this premature, constant estrogen signal from the fat tissue. It assumes the reproductive system is further along than it actually is, and it triggers earlier menarche.
And the clinical manifestations pile up pretty quickly from there, don't they?
Oh, yeah. You are looking at early menarche, but accompanied by profound systemic insulin resistance. And this combination is a primary driver in the development of polycystic ovary syndrome, or PCOS.
Which is so common. And you see these physical markers presenting in the clinic, too, like those dark, velvety discolorations in the body, folds and creases.
Right, acanthosis nigricans.
Yeah, or even severe joint and skeletal issues in adolescents carrying that excess load.
Well, acanthosis nigricans is the dermatological presentation you're describing.
Yeah.
And that's a direct, visible marker of severe insulin resistance.
Wow.
And on the orthopedic side, we see conditions like slipped capital femoral epiphysis.
What happens there?
That's where the head of the femur actually slips backward off the neck of the bone. It's due to altered growth plate dynamics combined with the sheer mechanical overload.
That sounds incredibly painful. But I need to pause here and ask a mechanistic question, though, because there's a paradox here that always trips people up.
Okay, what is it?
If this rogue adipose tissue is producing extra estrogen through that aromatase enzyme, why do obese adolescents with PCOS present with hyperandrogenism? I mean, why are we seeing excess male hormones driving severe acne and hirsutism, excess hair growth, if they're making so much estrogen?
The missing link in that paradox is insulin.
Insulin.
Yes. You have the excess visceral fat, which creates systemic insulin resistance. So the pancreas responds by pumping out massive amounts of insulin to try and, force glucose into the cells.
Right. It's working overtime.
Exactly.
Yeah.
This compensatory hyperinsulinemia hits the liver incredibly hard. And one of the liver's vital jobs is producing a protein called sex hormone binding globulin, or SHBG.
Which acts like a like a biochemical taxi cab for hormones, right?
That's a great analogy.
Yeah.
SHBG binds to hormones like testosterone while they're in the bloodstream. He keeps them biologically inactive while they circulate.
Okay, I follow.
But those chronically high levels of insulin actively suppress the liver's production of SHBG.
So the fleet of taxi cabs is suddenly cut in half?
Exactly. And without those cabs, you get a massive surge in free, biologically active, circulating androgens.
Oh, wow.
Even if the patient's total testosterone hasn't skyrocketed, the usable amount has. It's this free testosterone that hits the hair follicles, driving that hirsutism, and hits the ovaries.
Which impairs normal follicle development.
Right, creating the classic cystic appearance of PCOS.
That insulin mechanism clarifies so much. The resistance basically strips away the binding proteins and unleashes the androgens.
That's exactly what's happening.
Naturally, a patient dealing with these early hormonal storms, irregular cycles, and metabolic hurdles might eventually want to regulate their system or, manage their family planning.
Absolutely.
But these issues don't just resolve, they cascade. Which means when a patient attempts to either prevent pregnancy or conceive, routine clinical interventions suddenly become massive liabilities.
Yeah, we hit a crossroads here of mechanical, pharmacokinetic, and physiological barriers. Let's examine contraception first.
Okay.
Prescribing standard combined oral contraceptives, specifically the estrogen component, to a patient with obesity carries a significantly compounding risk for venous thromboembolism, or VTE.
Blood clots. Because the baseline risk for a dangerous blood clot is already elevated due to the systemic inflammation caused by the adipose tissue itself, right?
Right. Introducing oral synthetic estrogen amplifies that risk exponentially.
But the clinical picture gets even more complex if the patient has actively treated their obesity through bariatric surgery, like a Roux-en-Y gastric bypass.
Oh, definitely. This introduces a severe pharmacokinetic challenge. Bariatric surgery is designed to create malabsorption in the gastrointestinal tract to force weight loss.
Right. By bypassing a large portion of the stomach and small intestine, the anatomy is fundamentally altered.
Exactly. This means oral medications, including daily contraceptive pills, are no longer absorbed reliably.
So trying to use oral contraceptives in a post-bariatric surgery patient is kind of like trying to fuel a car while driving on a deeply potholed road.
That's exactly it.
The absorption is totally unpredictable. I mean, one day the patient might get the full hormonal dose. The next day it might pass right through their system unabsorbed, leaving them entirely unprotected against pregnancy. We have to bypass the digestive highway altogether.
We do. The clinical gold standards in these scenarios shift entirely to long-acting reversible contraceptives, or LIRCs.
Like an IUD.
Right. The levonorgestrel-containing intrauterine system, the LNG-IUS, or etinogestrel subdermal implants in the arm, those become the primary recommendations.
Because they deliver a steady state of hormones directly into the local tissue or bloodstream?
Exactly. Completely bypassing the compromised GI tract and avoiding that systemic estrogen that spikes the clot risk.
So that's the hurdle for preventing pregnancy. But when the patient is actively trying to conceive, we run into a totally different physiological barrier at the cellular level, don't we?
We do. When you dig into the pathophysiology of infertility here, you encounter this concept of lipotoxicity.
Lipotoxicity.
Yeah. It's not just about scrambled hormonal signals anymore. It's about the physical, chemical toxicity of the fat itself.
Meaning the fat is literally poisoning the reproductive cells.
Essentially, yes. Elevated levels of circulating free fatty acids actually infiltrate the follicular fluid in the ovary. These fatty acids induce severe oxidative stress.
Wow.
Which leads to mitochondrial dysfunction within the oocyte, the egg cell itself.
So this chemical environment physically damages the cellular structure.
Right. It causes spindle abnormalities, which is why we see significantly lower success rates, even with advanced interventions like in vitro fertilization.
And even if you have a healthy, fertilized embryo ready for transfer, that lipotoxicity alters endometrial receptivity. The lining of the uterus becomes chemically hostile to implantation.
It does. And we also have to be crystal clear here that this is not exclusively a female reproductive issue.
Right. The metabolic impact is equitable. Male obesity severely disrupts the fertility equation, too.
Absolutely. Male obesity drastically reduces semen quality. We see high rates of sperm DNA fragmentation and reduced motility.
Is that driven by the same aromatase mechanism?
Mechanistically, part of it is, yeah. Peripheral aromatase converting the male's testosterone into estrogen. But a huge factor is actually sheer physics. Excess scrotal fat creates testicular hyperthermia.
Oh, because the testes reside outside the core of the body because they need to be cooler than standard body temperature to produce viable sperm.
Exactly.
So that excess adipose tissue acts as an insulating blanket, raising the local temperature. It essentially bakes the sperm, causing massive DNA fragmentation.
It's a mechanical and environmental disruption.
So whether the goal is preventing pregnancy or promoting it, the physiological barriers are just immense. But what happens when these metabolic disruptions lead to abnormal bleeding or severe pain, and we actually have to look inside the pelvis or operate?
Well, this physical mass transforms routine procedures into absolute battlefields. The presence of excessive adipose tissue creates profound obstacles in both the diagnostic phase and the operating theater.
Let's start with diagnostics. Ultrasound is usually the cornerstone of gynecological imaging, right?
Right. And ultrasound relies on sound waves bouncing back to create an image. But adipose tissue causes severe acoustic impedance.
Meaning the fat physically scatters the sound waves.
It does. The high-frequency waves, which are required for high-resolution, detailed images of the ovaries and uterus, simply cannot penetrate the thick layers of abdominal fat. The image just degrades into static.
So what do clinicians do?
They are forced to use lower-frequency probes to penetrate deeper, but that sacrifices vital diagnostic detail. To get a clear view, they frequently have to bypass the abdominal wall entirely.
Relying on transvaginal or transrectal ultrasound approaches instead. And what they are often searching for, tragically, loops right back to our central mechanism. Because there is a deeply sinister link between obesity and female malignancies, specifically breast and endometrial cancer.
There is. Let's call back to that aromatase enzyme we discussed during the onset of puberty. Adipocytes are constantly converting androgen precursors into estrone.
Right.
Over decades, this leads to a systemic, dangerous spike in bioavailable, unopposed estrogen.
And unopposed meaning there isn't enough progesterone being produced to balance it out. Usually because the obesity and PCOS have stopped the patient from ovulating regularly.
Precisely. Without progesterone to stabilize the tissue, that constant estrogen stimulation causes the endometrial lining of the uterus to thicken uncontrollably, a state called endometrial hyperplasia.
And over time, those rapidly dividing cells accumulate genetic mutations.
Yes. Because the cellular turnover is so unnaturally high, the repair mechanisms fail, driving the progression straight into endometrial carcinoma. The adipose tissue is actively feeding the mechanism of oncogenesis.
That is terrifying. So let's say a diagnosis is made. The patient needs surgery, say a hysterectomy, or an oncology staging procedure. Treating these patients surgically requires navigating incredibly high-risk physiology.
Extremely high risk. For one, the incidence of obstructive sleep apnea is massively elevated.
Because the sheer weight of the neck tissue causes the airway to collapse during sleep.
Right, and for an anesthesiologist, managing the airway, intubating, and especially extubating the patient after surgery is incredibly treacherous.
What about the mechanical challenges?
Well, beyond the airway, positioning an obese patient on the operating table requires specialized equipment. We are talking about extreme care to avoid devastating nerve damage, such as brachial plexus injuries in the shoulder.
Because the sheer weight of the patient's own body pulling against the surgical restraints during a multi-hour procedure can cause permanent nerve avulsion.
Exactly. It's a major concern.
Wait, I'm genuinely stuck on something regarding the surgical approach here. The clinical standard dictates that minimally invasive laparoscopic surgery is highly recommended over traditional open surgery for obese patients, right?
It is, yes.
Because you want to avoid making a massive open abdominal incision. Cutting through inches of adipose tissue carries a notoriously high risk of severe wound infections and poor healing.
Right, laparoscopy is the preferred standard.
But to do laparoscopy, you have to pump the abdomen full of carbon dioxide gas to create a working space, a pneumoperitoneum. If the patient is already struggling with respiratory compromise from the weight on their chest, how does pumping their abdomen full of high-pressure gas not cause their entire cardiovascular and respiratory system to fail?
You've highlighted one of the most intense clinical paradoxes in the operating room. It is a minute-by-minute physiological tightrope walk.
Wow.
On one side of the drape, the surgeon absolutely needs higher intra-abdominal pressures from that gas. They have to lift the heavy abdominal wall and push past the dense visceral fat just to see the organs safely.
They physically need the room to maneuver the trocars and instruments.
Exactly. But on the other side of the drape, the anesthesiologist is managing a cascade of physiological nightmares. That high-pressure gas pushes the diaphragm high up into the chest cavity, severely compressing the lungs.
So they have to use higher positive pressure on the ventilator just to force air in.
Right. Furthermore, all that pressure in the abdomen squeezes the inferior vena cava. That's the major vein returning blood from the lower body to the heart.
Oh, man.
This drastically decreases cardiac preload.
So the blood physically struggles to get back to the heart to be pumped out again, which means blood pressure plummets.
Exactly. The surgical team must maintain a razor-thin balance. Enough gas pressure for the surgeon to see and cut safely without causing accidental injury, but not so much pressure that the patient's venous return drops so low they go into cardiac arrest.
It's a literal tug-of-war with the patient's physiology. The complexity of what might be considered a quote-unquote routine laparoscopic hysterectomy in a non-obese patient is staggering.
It really is.
But the impact of obesity isn't just felt in these high-stakes acute surgical moments. When we step out of the operating theater, we have to confront the chronic toll.
Yeah, the everyday reality.
The daily quality of life, the pelvic floor mechanics, and the heavy psychosomatic burdens these patients carry every single day.
Let's look at the pelvic floor mechanics first. We just discussed the intense intra-abdominal pressure created artificially during surgery, right?
Right.
Well, obese patients live with chronically elevated intra-abdominal pressure as their baseline. The profound weight of the visceral fat presses down relentlessly on the bladder, the urethra, and the supportive pelvic floor muscles.
And over years, this constant mechanical overload stretches and weakens those structures, leading directly to urodynamic stress incontinence.
Exactly. A simple cough, a laugh, or physical exertion overwhelms the weakened sphincter, and leakage occurs. It's a daily physical grind.
But the burden isn't purely mechanical, is it? It's highly biochemical.
It is. We know the fat acts as an endocrine gland for hormones like estrogen, but it also functions as a massive factory for pro-inflammatory cytokines.
Cytokines?
Yeah, we are talking about signaling molecules like interleukin-6, IL-6, and tumor necrosis factor alpha, TNF-alpha. These cytokines flood the bloodstream, creating a state of chronic systemic inflammation.
And what is devastating for the patient's daily quality of life is how this systemic inflammation interacts with the central nervous system, right?
Absolutely.
Those inflammatory markers actually lower the threshold of the body's pain receptors. They sensitize the nervous system. It's like the body is in a constant state of low-grade alarm.
Yeah, that's a great way to describe it.
The fat cells are essentially sounding a chemical siren that turns the volume up on every single pain signal passing through the spinal cord to the brain.
Clinically, this is known as central sensitization. Because of this primed nervous system, conditions that are inherently painful, like chronic pelvic pain, endometriosis, or abdominal myofascial pain syndrome, are severely amplified.
So the patient isn't just carrying a heavier mechanical load. Their neurochemistry is physically altering how they perceive pain, making it sharper and more persistent.
Yes.
Which transitions us into the critical psychosomatic dimension of treating this population. The clinical data emphasizes a remarkably high incidence of psychosexual disorders, profound anxiety, and a severe fear of medical settings among obese patients.
And understandably so. Many have complex histories of psychological trauma, and almost universally they have experienced pervasive weight bias within the healthcare system itself.
The medical trauma is a significant barrier to care. Patients report being dismissed constantly cold that every single ailment, from irregular bleeding to severe pelvic pain, is simply a consequence of their weight.
Right. Their symptoms aren't investigated, they're just told to lose weight.
And this repetitive dismissal creates an environment of shame. The anxiety of stepping into a clinic, anticipating a lecture, or a dismissive attitude becomes so high that patients avoid seeking preventative care entirely.
Which is incredibly dangerous. They skip routine screenings like cervical smears or mammograms. And given the elevated oncological risks we just discussed, that avoidance can be fatal.
So how do clinicians counteract this?
Clinical best practice requires the application of self-effacement.
Self-effacement.
Yes. This is the professional virtue where a clinician actively identifies and puts aside their own biases, frustrations, or societal preconceptions. It requires centering completely on the complex reality of the patient in front of them.
It's recognizing clinically that you are managing a highly complex neurometabolic disease, not judging a moral failing.
Exactly. Without that profound active empathy, building clinical trust is impossible. And if a patient refuses to get on the exam table because the clinical environment feels hostile, all the advanced pharmacological and surgical knowledge in the world becomes entirely useless.
The medicine is truly only as effective as the trust in the room.
Perfectly said.
So let's pull all these threads together and summarize the massive medical journey we've mapped out today. We started by completely redefining adipose tissue. It is an active, rogue endocrine disruptor.
Right. It utilizes aromatase to pump out estrogen, initiating early puberty and driving the pathology of PCOS through severe insulin resistance.
It creates formidable barriers to family planning, introducing pharmacokinetic nightmares for oral contraceptives, especially post-bariatric surgery, and driving lepotoxicity that degrades egg and sperm quality.
It fuels the progression of cancer by supplying the unopposed estrogen that drives endometrial hyperplasia.
It turns the surgical theater into a physiological tightrope walk of respiratory and cardiovascular compromises, and it inflicts a heavy daily toll through mechanical pelvic floor stress and cytokine-driven central pain sensitization.
It is a total systemic hijacking of the reproductive baseline.
So think about how all this interconnected science plays out in practice. For you listening, put yourself in the clinic for a moment. Imagine a 35-year-old female patient presents to you requesting reliable contraception. She has a BMI of 42. Critically, you see in her chart that she had a Roux-en-Y gastric bypass surgery 1 year ago.
Okay, classic scenario.
Based on the pathophysiology we've unpacked today, which contraceptive methods are contraindicated due to absorption issues, and what is the safest, most effective alternative you must recommend?
Take a second to trace the pharmacokinetic pathway, right?
Exactly. Because of the gastric bypass, her gastrointestinal anatomy is fundamentally altered. She has severe malabsorption. Therefore, you must avoid all combined oral contraceptives. Those daily pills will not absorb reliably, leaving her unprotected.
Furthermore, adding synthetic systemic estrogen spikes her already elevated VTE risk.
So the safest, most effective choice is to bypass the gut entirely. You recommend a long-acting reversible contraceptive, a LARC, such as the localized levonorgestrel-containing intraverterin system or an dermal implant.
And that bridges the underlying metabolic science directly to practical, safe patient care.
But before we wrap up this deep dive, there is one final, intensely provocative concept in the literature that stretches this science into the future. We've talked about how adipose tissue affects the patient, but there's an entire field of study dedicated to epigenetic programming.
Yes, this is fascinating.
When a pregnant patient has severe obesity and metabolic syndrome, that altered biochemical environment, the high glucose, the free fatty acids, the inflammatory cytokines, actually programs mitochondrial dysfunction into the DNA expression of the fetus.
Through processes like DNA methylation, the intrauterine environment alters the genetic baseline of the developing child. It primes their metabolism for dysfunction before they are even born.
Increasing their lifetime risk for cardiovascular disease and obesity.
Right.
And here is the truly staggering part. This altered genetic expression can persist across multiple generations. So, we leave you to ponder this as you move forward in your studies or your practice.
The big question.
If the metabolic environment of a single pregnancy permanently alters the DNA expression of the next generation, how does that shift the weight of clinical responsibility? When you are sitting in the exam room working with a pregnant patient managing severe obesity, are you just treating the one patient sitting in front of you? Or are you, simultaneously, treating the biological baseline of their unborn grandchildren? It's a heavy, profound thought. It is. But it all traces back to the very first thing we discussed. The tissue we are dealing with isn't just passive storage. That rogue endocrine organ is actively rewriting the biological script, not just for the individual, but potentially for generations to come.